Good morning, everyone. It is Tuesday and January the 12th. It's 9 a.m. here in Cleveland, Eastern Standard Time. My name is Ashok Agarwal. I'm your host for the next 2-3 hours. And I want to, first of all, before we begin the program, want to wish you a very happy New Year 2021. I wish you good health and a lot of happiness, and I hope that we will be able to see many of you during this year after the pandemic is under control. So thank you again. And today is a very exciting program. We are here to discuss and present virtually our online ART training. Today is the third program in the series. We began in November. We presented first program in November, then second one in December, on December 8th. And today is our third program on January the 12th. Today's program is on Ancillary Semen Test. So let me begin without taking any further time and begin my introduction. Very briefly, this is my biography, a very brief biography, just to provide few highlights. I am in charge of the Andrology Center at Cleveland Clinic for the past 28 years. I'm the director of the American Center for Reproductive Medicine, which is the host of this online virtual training session. I'm a professor of surgery in urology at the Lerner College of Medicine at Case Western. I'm a staff in urology and in some other department. Our group is very well known in the area of male infertility, andrology, and human-assisted reproduction, and we are ranked as #1 in terms of our publications based on the Scopus, which is one of the premier service in terms of the literature in the medical field. Our group has published a very large number of books in the field of male infertility, ART, fertility preservation, DNA damage, and antioxidant. Our laboratory has trained over 3,000 scientists, clinicians, graduates from more than 100 countries. The organizers and speakers of this program have no conflict of interest. We have taken no sponsorship or asked any company for that. This program is made entirely possible by the support from our foundation, from our own center, and the webcasting support has been provided by our colleagues, David Reichling and David Wolfley. Course faculty have generously donated their time for this online training, and our program coordinators, who you will see in a minute, have graciously volunteered their valuable time to manage this program. Lastly, the names, images, and description of products or instruments that you may see during the lectures or which will be discussed during the presentations are not being endorsed. They are being used routinely in our program. So this is today's program. The learning objectives today is we have a very, very good program today, and you will see this is part of the semen analysis, and it is like a hidden gem. Most people will not know many of these tests that are basically done as part of semen analysis as indicated, So we are going to discuss about the leukocytospermia or detection of white blood cell or infection, sperm vitality testing, anti-sperm antibody screening, special test for azoospermia, post-vasectomy screen, and screening for retrograde ejaculate. So I can tell you that today's program is by far going to be the very best. We have invested enormous amount of time in preparing for these lectures. They have been well researched, well prepared, and practiced dozens and dozens of time what you are going to see today. So for each lecture, we have spent almost 30-40 hours minimum in practice sessions, and each lecture has gone through at least 10 or 12 practice sessions with multiple people, and each content has been well researched through the literature with proper references, and to make sure everything is extremely accurate and simple for you to understand. So this is our program today in a diagram. As you can see, the last lecture is going to be by our clinician, who's going to really put it all together to explain what these tests really mean to you. Dr. Sharma spoke very nicely about a little known test called vitality test, and he explained the differences between vitality and viability. Two very important differences, one for diagnostic, one for therapeutic. And now we dive into the next topic, which is on anti-sperm antibodies. And our next speaker is Dr. Sajal Gupta. Dr. Gupta is a veteran of our andrology program. She is the technical supervisor of our center, which runs 3 laboratories in different parts of Cleveland Clinic, in different cities. And also we have a very large reproductive sperm and semen bank for cancer patients. Dr. Gupta has a distinguished career. She has done her fellowship in reproductive medicine with WHO, and then a research fellowship with our program. She has been highly decorated, as you can see. She has also done a master's in embryology from the Jones Institute. She is a very passionate andrologist who really takes care of our patients in the most compassionate manner. And today I invite her to speak about the issue of anti-sperm antibody test. So Sajal, you can present if you want.
Thank you very much, Dr. Agarwal, for the introduction, and welcome to all the participants. Good morning from Cleveland. And the presentation that I'm going to be making is on anti-sperm antibody test. Next slide. The learning objectives of this talk are indications for anti-sperm antibody testing, review the principle and protocol for the technique by which we do the anti-sperm antibody test, which is the mixed antiglobulin reaction, and in short, it's called the MAR test. Learn scoring, calculation, and reporting of the results by this test, and recognize the importance of quality control, quality assurance, and troubleshooting. Next slide, please. So this slide illustrates the indications for sperm MAR test. So the most important indication is sperm agglutination, which could be mild, moderate, or severe. And on the right side, you can see on the illustration the presence of sperm that are agglutinated to each other. The second is low total motility, low progressive motility, vasectomy reversal. Any disruption in the barrier of the blood testes barrier can result in formation of sperm antibodies. Scrotal injury, which again leads to disruption of the barrier, previous miscarriages, and poor IVF outcomes. Next slide. So the equipment and supplies that are needed for conducting this test are the bright field microscope using the 20x magnification, phase contrast, and with the green filter. The others are what are listed are the incubator and some other supplies. And finally, what is needed is a fixed cell sperm counting chamber and a humidified chamber in which the samples are incubated. Next slide. So the reagents listed are, and we have provided the illustrations on the right side. The first important reagent is the MAR test IgG kit. And this kit is illustrated as the first illustration, and it is labeled. So this has initially the suspension of the polystyrene latex beads, which are 2 micrometers in diameter, and these are coated with the human IgG. And then there is the MAR anti-serum, which is containing the monoclonal antibodies towards the fragment C of the human IgG. The second important reagent is the controls, which are the positive and the negative controls. And these are run in the assay to make sure that the assay is run correctly. The third illustration on the top is the IgA kit. So this IgA kit has the latex beads and the anti-serum in a single solution. And you can see our technologist at the bottom. She's performing the sperm MAR test. Next slide. What is the principle of the MAR test? Essentially, there are 3 immunoglobulin classes, IgA, IgG, and IgM. But in the semen sample, the main antibodies are IgA and IgG. And what leads to the antibody production is the autoantigenic properties of the spermatozoa. And on the right side, you see the illustration where the beads are attached to the spermatozoa and the beads are coated with the antibody to the IgA. And these will attach to the sperm-bound IgA antibodies. So basically, there is a bridging antibody which is connecting the beads to the spermatozoa. And the motile spermatozoa and the beads will form mixed agglutinates, and that's why it's called a mixed antiglobulin reaction. And it can be tested against both IgA and IgG antibodies. And the binding of the beads indicate the presence of IgA or IgG antibodies. Next slide. So here I'll show you a short video clip of how the test is performed, the IgG test. And you can see these are there's a humidified chamber. So the slide is labeled, the semen sample, 10 microliters is placed on the slide. Next, we place the beads from the IgG, 10 microliters, and then the semen and this beads are mixed well. Next, we take the anti-serum 10 microliters and add it to the mixture, and then mix the sperm sample, the beads, and the serum. And then a cover slip is placed on the slide. This slide is placed in the humidified chamber. We place a timer for 3 minutes. So once the incubation is done, the reaction has happened, then this slide will be examined on the phase contrast microscope. Next slide, please. So what is the significance of positive IgA and IgG antibodies, which are both tested in the semen sample? The IgA antibodies have greater clinical importance than IgG antibodies. Essentially, the beads will bind to the motile and immotile spermatozoa, which have the surface-bound antibodies. And this is illustrated in a very nice illustration on the right side, the binding of the beads to either the head or multiple sites of the spermatozoa where they are bound, and the percentage of motile spermatozoa with the bound beads is recorded. So the important thing to understand is just count the motile spermatozoa with the bound beads. Next slide. Here, what are the quality reagents? The quality control reagents are basically decomplemented patient serum, which is diluted in cell culture medium, and both positive control and negative control is provided with the kit. These are warm to room temperature before use, and the shelf life is about 18 months. Next slide, please. So here I've provided a step-by-step protocol of how the MAR IgG positive and negative controls are run. So the first step is to vortex both the controls well before use. And the second step is we use a known negative. Known negative means this donor sample. It's a normospermic subject, and his sample was already tested for antibody and was negative. And this sample, to this sample, we add modified human tubular fluid, twice the sample volume. And once we have added the HTF, this is mixed well, the step 4, and then this sample is spun for 10 minutes at 1600 RPM. And once the centrifugation is done, the fifth step is to remove the supernatant and leave some of the supernatant, about 100 microliters, to mix the pellet. And this last step is used, washed donor sample is used to test the negative and the positive controls. And this I will illustrate in a video clip in the next slide. Next slide, please. So here, the semen sample from the donor is there, and then modified HTF is added, twice the volume. This mixture is placed in the centrifuge for 10 minutes. The aspiration of the supernatant is done. The pellet is left undisturbed. And then the pellet is reconstituted with some more fresh modified HTF. And the concentration should not be higher than 50 million. So this is the positive control. 50 microliters of the positive control is added to the amber-colored vial. And then the donor sample is added 50 microliters. Same is done for the negative control. And then once the mixture is in the vial, these vials will be incubated for 1 hour for the reaction to happen. And then the actual testing will be done with the IgG beads as well as the IgG anti-serum to check whether the positive ran positive or the negative ran negative. Next slide. So to examine the sperm MAR test scoring, what are the basic principles? The latex beads bind to the spermatozoa with antibodies on their surface, and there could be few beads or multiple beads that may attach to the motile spermatozoa. So as a result of the binding of the beads, the motility is reduced, and especially when there are large clumps of beads binding to the spermatozoa. The sperm, which do not have the antibody coating, will swim freely between the beads. So we will count only motile spermatozoa, and a total of 100 is counted, the ones that are attached versus the ones where there is no bead attachment. The ultimate goal of this test is to evaluate the percentage of motile spermatozoa with the beads attached. Next slide, please. So going further, how do we read the results? We use the 20x objective, as you can appreciate in the illustration on the right, and use the phase contrast with the green filter. And then count 100 motile spermatozoa twice to assess the percentage of sperm binding to the beads. What you report is the average of the two values you have obtained, and the test is reported as positive if greater than or equal to 40% of the sperm have beads attached. And this is per the IgG kit, the manufacturer recommendations that any test where it is greater than or equal to 40% binding should be reported positive. Now, as per a publication from Human Reproduction from Lotti et al., they have reported a prevalence of MAR test positivity in the 5 to 15% of infertile males. So it is an important cause of infertility. Next slide, please. Here I have an illustration of a negative control sample. So you could play the video. And what I want to show is basically there are beads, clumps of beads, but the spermatozoa are predominantly swimming or moving freely, so they are not bound to the beads. And so we have the negative control run as a negative, and we know the test is performed accurately. Next slide, please. Oh, there was another one. Please go back. The positive control. So here you will appreciate the positive control. And what I want to show you here is the clump of beads and the spermatozoa that are attached in this clump, and they're attached either by the tail or by the head, but they are basically bound to the beads. And so this was a positive control. Reporting of results, negative results are reported if less than 40% of the sperm is bound to the beads. Positive results, how do we report and record? Positive if greater than equal to 40% of the sperm is bound to the beads. We report the person binding, and we report the area of bead attachment, whether the head, mid-piece, because if it's bound to the head, then the clinicians have to make a separate judgment call. And on the right, you can see and appreciate the different areas where the sperm is bound. The first one shows the binding to the head. The second shows to the tail. At the bottom is a negative result where there is sperm that is swimming and there's no binding. Next slide, please. So quality control is an important component of the anti-sperm antibody testing. And in our laboratory or other laboratories perform the proficiency testing. So this is an example of two analytes. We are sent two analytes, and the numbers are provided 17 and 18 by the College of American Pathologists. So the first analyte with the red box shows 4% binding. It is negative. The second analyte shows 87% binding, and it is positive. And then the negative and the positive controls results are also shown. The positive control, 97% positive binding. Negative control, there was 13% negative binding. So we know the results are accurate, and this is what we report as part of EQC. Next. So these are the results for both the analytes, and the intended response matched what our results were. So the lab is performing the test accurately and reporting the results well. Next slide. So here is a scenario for a negative ASA IgA test. And this was an IgA ASA, or the anti-sperm antibody test, performed for a sample with sperm concentration of 15 million, motility of 45%. How do we calculate the percent total binding? It's number of sperm with bound beads upon total number of sperms counted and reported as a percent. So when we examine under the microscope, what we saw was free total motile 75, bound total motile 25. So the percent total binding is 25, and the result is ASA IgA test negative. Remember, the cutoff is greater than equal to 40%. Next slide. This is scenario 2 that is illustrating a semen sample with low motility. So this was a semen sample with 5% motility. And these are the patients where anti-sperm antibody is ordered by the physicians, and a concentration here was 2 million. When the sample was examined under the microscope, there were less than 100 motile sperm on the wet prep. Person binding cannot be reported due to very few motile sperm, and hence the result was not reported to the clinician because of very low motility. Next slide. So this is a recent study published in Human Reproduction, which examined the significance of positive MAR tests. So on the first panel, the bar diagram shows % of men with MAR test positivity. They took a cutoff of greater than 50%, and this was examined in males of fertile couples versus male of infertile couples. And you can appreciate that there was significantly higher number of positivity in males of infertile couples. The second bar diagram shows comparison of positive MAR test and negative MAR test in men with history of epididymitis. Epididymitis is, again, there is a disruption of the blood testis barrier, and what they have reported is a higher % of MAR test positivity in patients with epididymitis. So It can be positive in patients with orchitis as well as in patients with epidermitis. Next slide. So I would like to sum up with some take-home key points. MAR test is useful in the diagnosis of immunological infertility. It is important to test for both antibodies, IgA and IgG. And anti-sperm antibodies do play an important role in male infertility, as has been demonstrated by several publications. And proficiency testing, or EQC, is an important tool for reporting accurate anti-sperm antibody results. On the right, you see our andrological evaluation of male infertility. This has the protocol for the MAR test provided in it. Next slide, please. So this is our group in front of the Andrology Center. And I thank you all for your attention.
You can. So the next presentation is going to be again by my associate, Dr. Sajal Gupta, and she's going to be speaking about a very common but very important test called post-vasectomy semen analysis. So again, I think this is a very common test because vasectomy is one of the most common method of contraception, at least in the United States and in many parts of the world. So to really to provide the clarity to the patient when the procedure for vasectomy has been performed, when they are cleared of any type of spermatozoa, this test is very critical. But there is a lot more than you may know about this test. This is what we are going to talk about today. So let me stop my video and myself and let Dr. Gupta present her talk now.
Thank you very much, Dr. Agarwal. Previous slide, please. So good morning once again. The topic of my presentation is post-vasectomy semen analysis. Next slide, please. The learning objectives. Firstly, the indications for the test. Then learn how to do post-vasectomy semen analysis. Review the AUA, or the American Urological Association guidelines, and reporting of results. Also learn the importance of external and internal quality control, as well as quality assurance associated with this test. Next slide. So here, this slide provides the post-vasectomy semen analysis workflow, or the step-by-step procedure of a post-vasectomy semen analysis. The test is performed 3 to 4 months after the vasectomy procedure, and the patient is provided instructions for specimen collection. This could be collection at a lab where they are provided instructions about maintaining the abstinence time of 2 to 7 days. If they're collecting at home, then instructions to collect after the appropriate abstinence time, collect in a sterile container, and transport the sample within an hour and keep the sample at body temperature. And then the performance of the semen analysis. So on the right side, you see the phase contrast microscope, which is used. And at the bottom is provided the semen analysis before vasectomy, after 3 months, where majority of the times sperm will not be seen, but in some samples sperm is seen, and we will describe these scenarios. And after 6 months of the vasectomy, no sperm will be seen. So the reporting of results will also be important. Next. The equipment and supplies, I have illustrated the bright field microscope, phase contrast, green filter that is used, and then the various other supplies for semen analysis, and of course the fixed cell sperm counting chamber. On the right side, you see Dr. Agarwal looking at a semen analysis from a post-vasectomy sample. Next slide. So the stepwise protocol is a post-vasectomy semen analysis includes examining the volume of the sample, preparing a wet prep, and estimation of round cells. The finding of no sperm seen should be reported after complete screening of 2 wet prep slides, and these wet prep slides are prepared on a fixed cell chamber. There are 2 wells, so you could simultaneously aliquot the sample on the 2 chambers and examine them. A definite report of no sperm seen can be made exclusively from wet prep without the need to examine the spun sample. So this is a very key takeaway, that there is no need to examine the spun sample. Next slide. PVSA guidelines. So these are the American Urological Association guidelines, and they've provided the definitions for post-vasectomy semen analysis. The first is azoospermia, where there is absence of sperm during microscopic examination of at least 50 high-power fields in a single, well-mixed, uncentrifuged semen sample. The second, rare non-motile sperm, also abbreviated as RNMS, is presence of less than 100,000 non-motile sperm per ml, again based on similar microscopic examination as the first one. And then recanalization is a histologic diagnosis, which they have provided the definition. Next slide, please. The post-vasectomy results categorized based upon the AUA guidelines. So these are 5 scenarios I have provided. And the first and the second, if you examine the first one, the sperm concentration was greater than 100,000 non-motile sperm per ml. And this does not meet the AUA guidelines. Whereas the second one, in contrast, where the sperm concentration was less than 100,000 non-motile sperm ml, meets the AUA guideline, and the test will pass the AUA criteria. Similarly, the third scenario, less than 100,000 per ml sperm, meets the AUA criteria. Whereas scenario 4 and 5, there's presence of a rare motile sperm, which will not meet the criteria. And 5th also has a rare motile sperm, which makes it not meet the AUA guidelines criteria. And these tests have failed the AUA guidelines. Next. So this is a recent study from last year where the study examined the post-vasectomy outcomes and the follow-up of these patients. Are there any patients that are lost to follow-up? So this was a big study where more than 4,000 men were examined, and this was conducted at the Mayo Clinic. And the first bar diagram shows the initial, which is the first post-vasectomy semen analysis results. So majority of the men passed the test per the AUA criteria, either had azoospermia or rare non-motile sperm, the blue and the green figures. But look at the right side. In the red box is the men who failed the AUA criteria. Either they had greater than 100,000 non-motile sperm per ml, or they had presence of motile sperm. So 14% of the men failed the first PVSA. Now at the bottom, the significant findings are listed. So what is important to appreciate here is that 61% of the men with failed first PVSA did not get a second post-vasectomy semen analysis. So there is a loss to follow-up, and the clinicians need to get to these men and make sure that they do the second PVSA as well. On the right side is the results of this repeat post-vasectomy semen analysis in 163 men. Majority, again, passed the AUA criteria guidelines, but 32.5% of the men, as seen in the red text box, failed because they had greater than 100,000 non-motile sperm. So these men will require a repeat PVSA and continued follow-up to make sure that these men are appropriately counseled and followed up. Next slide. So these are some more results. These are actual results, but we have anonymized, and these provide the results per the AUA guidelines. So if you look at the first three results, they have failed the AUA criteria. The first one had a concentration of 340,000 non-motile sperm plus had rare motile sperm seen. The second one, 2.4 million with motile sperm, fails the criteria. If you examine the last two sample results, you see that they have passed because sample number 4 had azoospermia, sperm concentration of 0.0, and the last sample had non-motile sperm less than 100,000 per ml. So the criteria is to have less than 100,000 non-motile sperm, and this will pass the test per the AUA guidelines. Next slide. Internal and external quality control is important for any test, and this is performed in all andrology laboratories. So the internal quality control is testing the quality of the fixed cell chamber, which can be done by doing the low control and the high control ACU beads or the latex QC beads are tested each day of testing. And once they are within the reference range and have met the quality control and have been reviewed, then the lab is ready to do the test. The bottom diagram shows the external quality control, and this is results of the post-vasectomy sperm count, 2 analytes, which are sent by an EQC agency. And the first box with the text box with the red outline shows the presence of sperm. And at the bottom is the concentration, which is 2.30 million per ml, and this failed the AUA guidelines. So this is what I wanted to highlight. The second sample, which is PVR04, in the second red text box shows absence of sperm. So no sperm were identified, and this sample had 0.0 sperm concentration or azoospermia. So this sample passed the AUA criteria, and the sample was negative on testing. Next slide, please. The overall take-home message is that post-vasectomy semen analysis helps confirm the success or failure of vasectomy. PVSA monitoring or repeat vasectomy may be considered by the clinicians if the results show more than 100,000 non-motile sperm per ml or any motile sperm. And so they need to be continually monitored, and the decision needs to be made by the clinician. The last take-home message is that the couple can be advised to stop other methods of contraception if the test shows less than equal to 100,000 non-motile sperm per ml. Next slide, please. So this is our group with Dr. Agarwal, our director, and then Dr. Witt, she's the male infertility director. And I thank you for your attention.
Connect with our program by connecting on our LinkedIn, and these are the benefits. Almost every single day, we provide update on our research activities by posting hundreds of research articles freely, completely downloadable that anybody can read. We also post the latest research which are presented at prestigious meetings such as ACRM, ASHRI, and AUA. You can learn about our virtual research opportunities, which we have just started. You can learn about our online training and opportunities to collaborate with our team. Just go to the LinkedIn and send a request to Ashok Agarwal, and it will, from Cleveland, and it will come to us, and we will allow you to connect to our program. This is actually the best way to learn all the advances that are happening.